So when you see a plastic surgeon in planning your reconstructive breast surgery, they're going to present to you a number of possible options for your breast reconstruction. Now, there's no question that there are 3 techniques that are the predominant ones that we use to reconstruct the breast after a mastectomy today. And they consist of implant-based or prosthetic breast reconstruction, using a patient's own tissue to reconstruct their breasts instead of an implant, what we call autologous reconstruction. And then lastly, a mix of the two, what we call a hybrid technique, utilizing both a patient's own tissue from other parts of their body as well as an implant. So for those patients who have chosen to pursue an implant-based breast reconstruction after mastectomy, your plastic surgeon will most likely discuss with you 2 options, what we call direct-to-implant reconstruction or a 2-stage breast reconstruction using what we call a tissue expander. Now, these are very different techniques, but ultimately produce the same final outcome of an implant-based breast reconstruction. With direct-to-implant reconstruction, the plan is to complete the entire reconstruction at the time of the mastectomy. So the same day that the oncologic breast surgeon performs the mastectomy and removes the breast tissue, your plastic surgeon will then come in and place the final implant during the same procedure. With a 2-stage reconstruction, the plan, as the name implies, is for your plastic surgeon to complete your breast reconstruction over 2 separate operations. Again, the reconstructive process will start at the time of the mastectomy, but here your plastic surgeon will place what we call a tissue expander on the day of the mastectomy. And then at the 2nd stage operation, a few months later, that temporary implant or tissue expander will be exchanged for the final permanent breast implant to complete the reconstruction. So when it comes to assessing the option of direct-to-implant reconstruction, there are both pros and cons to this technique. The pros, of course, are that the final reconstruction is achieved in one operation at the same time as the mastectomy. So the patient will go to sleep for surgery, have their mastectomy performed, and their immediate final implant placed at the same time, so they wake up with their completed breast reconstruction. Now, as far as cons go, the one downside to this option for some patients is that there's limitations in what size may be achievable with the implant at the time of the reconstruction, and what projection may be attainable at the time of the reconstruction. And so there's a little bit more of a size limitation than you may find with a 2-stage reconstruction. And so your plastic surgeon will help determine whether your goal size expectation with your reconstruction matches what is safely achievable with a direct-to-implant reconstruction. So the great news about implant-based reconstruction today is that thanks to the technology we have available when it comes to breast implants, as afforded by the Natrelle and Spiral line, is that there's a numerous variety and availability of different sizes and projections and what we call cohesivities or feels of breast implants. And so it may seem a little daunting to you as the patient in trying to start thinking about what type of implant you may ultimately want for your breast reconstruction and what type of characteristics you want for your breast reconstruction. Now, the good news is that your plastic surgeon should be well versed in helping guide you through that process. So my advice to patients is always, when you're starting to plan out your breast reconstruction and your final expectations for your type of implant, your goal size, your goal projection, your goal feel to your breast, really heavily depend on your plastic surgeon. Have them guide you through this process, show you the different types of implants available, show you examples of the different types of reconstructions attainable, and they should be your biggest help and guide in educating you what may best fit you for your final reconstruction.
Natrelle breast implants, important safety information and approved uses. Breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. Breast implants have been associated with the development of a cancer of the immune system called breast implant-associated anaplastic large cell lymphoma, BIA-ALCL. This cancer occurs more commonly in patients with textured breast implants than smooth implants, although rates are not well defined. Some patients have died from BIA-ALCL. Patients receiving breast implants have reported a variety of systemic symptoms, such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms when the implants are removed without replacement. Who can get breast implants? Natrelle breast implants are approved for the following: breast augmentation for women at least 22 years old for silicone-filled implants, and for women at least 18 years old for saline-filled implants. Breast augmentation includes primary breast augmentation to increase the breast size and revision surgery to correct or improve the result of a primary breast augmentation. Breast reconstruction. This includes primary breast reconstruction to replace breast tissue that has been removed due to cancer or trauma, or that has failed to develop properly due to a severe breast abnormality. This also includes revision surgery to correct or improve the result of a primary breast reconstruction. Who should not get breast implants? Breast implant surgery should not be performed in women with active infection anywhere in their body, women with existing cancer or precancer of their breast who have not received adequate treatment for those conditions, women who are currently pregnant or nursing. What should I tell my doctor? Tell your doctor if you have any of the following conditions, as the risks of breast implant surgery may be higher: autoimmune diseases, example lupus and scleroderma; a weakened immune system, example taking medications to decrease the body's immune response; planned chemotherapy or radiation therapy following breast implant placement; conditions or medications that interfere with wound healing and blood clotting; reduced blood supply to breast tissue; clinical diagnosis of depression or other mental health disorders, including body dysmorphic disorder and eating disorders. Those with diagnosis of depression or other mental health disorders should wait for resolution or stabilization of these conditions prior to undergoing breast implantation surgery. What else should I consider? There is a boxed warning for breast implants. Please see bold text at beginning. Many changes to your breasts following implantation are irreversible. If you later choose to have your implants removed and not replaced, you may experience dimpling, puckering, wrinkling, or other cosmetic changes, which may be permanent. Breast implantation is likely not a one-time surgery. The longer implants are in place, the greater the potential risk for complications. You will likely need additional surgeries on your breasts due to complications or unacceptable cosmetic results. Thus, you should also consider the complication rates for later revision surgery, since you may experience these risks in the future. Cancer treatments and surgery will affect the outcome and timing of breast reconstruction. Breast implants may affect your ability to breastfeed, either by reducing or eliminating milk production. Rupture of a silicone-filled breast implant is most often silent. Even if you have no symptoms, you should have your first ultrasound or MRI at 5 to 6 years after your initial implant surgery, and then every 2 to 3 years thereafter, regardless of whether your implants are for augmentation or reconstruction. If you have symptoms of or uncertain ultrasound results for breast implant rupture, an MRI is recommended. Additional imaging may be required depending on your medical history and status. The health consequences of a ruptured silicone gel-filled breast implant have not been fully established. Routine screening mammography for breast cancer will be more difficult, and implants may rupture during the procedure. Perform self-examination every month for cancer screening and ask your surgeon to help you distinguish the implant from your breast tissue. Lumps, persistent pain, swelling, hardening, or changes in implant shape should be reported to your surgeon and possibly evaluated with imaging. What are key complications with breast implants? Key complications include reoperation, implant removal with or without replacement, implant rupture with silicone-filled implants, implant deflation with saline-filled implants, and capsular contracture, severe scar tissue around the implant. Other complications include breast pain, swelling, asymmetry, wrinkling, rippling, implant malposition, nipple complications, hypertrophic scarring, and implant palpability visibility. Talk to your doctor about other complications. For more information, see the patient brochures at www.allergan.com/products. To report a problem with Natrelle breast implants, please call Allergan at 1-800-624-4261. The sale and distribution of Natrelle breast implants is restricted to licensed physicians who provide information to patients about the risks and benefits of breast implant surgery.